I'm Russ Glasgow. I'm a research professor in family medicine, and I direct the dissemination implementation program at Accords. And on behalf of Accords, I want to welcome you all. This is related to a really part of one of our health equity series seminars. And you can see right there, I won't go into any detail, but you can see right there some of the upcoming issues. Since this is totally virtual webinar, we'll handle things a little different in terms of questions and things. So we need people to use the chat function kind of at the bottom center right of your screen. So if you do have comments or questions, please feel free to go ahead and type those in. What we're going to do is let our guest, Dr. Neta, get about halfway through her talk, and then we'll pause for questions, then go the rest of the way through, and then we hopefully should have quite a bit of time for interaction. One thing that's a little different than usual is we actually can go, if there's involvement or questions, a full 90 minutes. So we don't need to stop right at the top of the hour. So you might just keep that in mind if you can stay with us or have questions that you may not be able to get in. With that, why don't, let's see, Gila or Jordan, do you want to go to the next screen anyway?
Is the next,
this is all
is the next screen my slides?
Yep.
I think they are, yeah.
Okay, so I will share my slides. Can you see them here?
There we go. Yeah, that's perfect. There you go. Good, good view.
Okay.
Okay. I'm gonna not take too much time, but just do a really brief introduction here, and then we'll let Gila get started. But it's both my privilege and pleasure today to introduce a friend and a colleague, Dr. Gila Neta, who's an epidemiologist and program director in the implementation science program at the National Cancer Institute. Some of you don't know this or know parts of it, but Gila actually has connections in a number of ways to our medical campus here. And just very briefly, and to kind of tie in some of her background, Gila worked on her doctorate of epidemiology at Johns Hopkins University, and I believe it was there that she was one of the mentees of Dean Samet of the School of Public Health. At least I know she is one of his mentees. Gila started at NCI in the Division of Cancer Epidemiology and Genetics, a real fascinating group there. And among other things there, she worked on projects with one of the, frankly, most brilliant and visionary people that I know, Moeen Khoury, who is an incredible boundary spanner. And I just want to toss out and encourage those of you on Twitter to think about following him. His last name is Khoury. And to give you an idea of what he's done, he simultaneously works at NCI and CDC, but he has developed a program on public health genomics, bringing together what most people think are two different fields. Very briefly, to finish up here, Gila herself is a boundary spanner. And when I was at NCI, we were fortunate enough to lure her from kind of the epigenetics folks to join our implementation science group there. And it's just been incredibly rewarding for me to kind of watch and observe her growth and increasing responsibilities since then. In addition to being the lead planner of the annual meeting with the at the end in December, the Academy Health and NIH annual D&I meeting, Gila has many interests. She'll touch on a few of them herself as a scientist and in promoting, including training, implementation science, use of BRACES2, economic evaluations, standardized pragmatic measures and de-implementation. But I will stop there with that and let her talk with you. And then again, I do think we should have plenty of time for interactions.
Great, thank you, Russ. And yeah, I'm glad to be able to be here in some form. I was sorry I wasn't able to come in person, but I'm hoping to provide all of you with these learning objectives. I realize Russ told me that many of you are already quite well versed in implementation science, but maybe not all of you. So I will provide a short, brief introduction and orientation. And even for those of you who are well versed, I've heard that hearing a summary or how different stakeholders conceptualize the field has actually been very useful. So folks like Amy Kilborn and Maria Fernandez even have said they've appreciated having these introductions just to see how we conceptualize it. I'll also talk, the bulk of my talk, Russ always likes to ask us to bring our checkbook. So while I don't have my checkbook, I will describe the funding opportunities that we have currently open, as well as some that we have recently closed and things that may be coming down the pike. And finally, just highlight, although while I'm talking about the funding opportunities, I will also be highlighting priority research areas within those. In addition, I'll conclude with a few additional priority research areas for advancing the field by talking a bit about the work of the consortium that was recently launched in implementation science. So starting with definitions, just wanted to start up front by distinguishing implementation science from implementation practice. Implementation practice is the use of evidence or interventions, whereas implementation science is the study of the use of evidence and interventions. So there have been a few nuanced ways that the field has defined itself, but essentially implementation science is defined as the study of methods to promote uptake of evidence in a variety of settings. And so what do we mean by evidence? There are a variety of evidence-based interventions, programs, practices, tools, and policies that have demonstrated effectiveness to improve health. But these programs, as we all know, are only as useful as they are actually implemented in practice. And as many of you know, and as recognized by the Institute of Medicine, now the National Academies, there is a substantial service delivery gap for these best practices and effective interventions, such that we aren't necessarily reaching all the populations who could benefit, and particularly vulnerable populations in low resource settings. So although there are platforms for the dissemination of many of these evidence-based interventions, tools, programs, etc., they are largely only used by researchers. Historically, researchers have often thought it wasn't our responsibility to ensure that our research is used. But we now know that the passive process of publishing—
Welcome to Verizon Wireless. Your call cannot be completed as dialed as the—
So this slide illustrates that problem. What this slide displays are the findings of a study from 2000 by Sue Boren and Andrew Bayless that asks the question, let's assume that that end product of our research is that high impact publication. What happens next? What you see in the middle of this slide is the rough publication pathway from publication of our original research to implementation, which they defined as 50% uptake. On the left side, you see all the ways we lose valuable evidence. And on the right side of the picture, they estimate about how long it takes to get through each one of these steps. And their conclusion was that it takes 17 years for only 14% of original research to benefit patients. So it shouldn't be the case that only 14% of evidence and that it takes 17 years. And again, that's just the time it takes to reach half of the people who could benefit. So we need to do a better job. And so the problem really goes beyond the strength of the evidence for effectiveness. An intervention is going to be only so good as how and whether it is adopted by different systems within different communities. But not just that, but that we also have an effort to identify those practitioners who can then be trained to deliver that intervention. And not just that, but we have a history of training providers where there isn't a way to come back from that training and incorporate the intervention into practice. So we need to make sure we think through that. And not just that, we also need to make sure that once those trained providers are able to deliver that intervention, that they can reach all those people who could potentially benefit from it. And even if we get halfway there at each of these steps, even though we know there's all sorts of issues with access, adherence, dosage, and maintenance, we're down to just a fraction of the benefit we thought we were going to have with that magic intervention. So we need to make sure that we don't just assume these steps are going to happen by themselves, but that we really think them through. And so I'm sure everyone on this webinar should be familiar with this, but essentially putting it another way, Russ did a great job, and the folks who developed Ream, to conceptualize essentially what are the main dimensions or goals of our field. So it's not just the effectiveness of our interventions, but these other dimensions that determine the ultimate value of our work: reach, adoption, implementation, and maintenance. And so these are some of the objectives of the field of implementation science. So returning to definitions, I wanted to highlight how we at the NCI use these terms. We see implementation science as bridging the gap between research and practice and policy by building a knowledge base on how evidence can be most effectively communicated and integrated into practice. For the purposes of our NIH funding announcements, which I will describe in a few minutes, we break it down into two different components. Dissemination research is the study of the targeted distribution of information and how best to spread or sustain knowledge and evidence, whereas implementation research is focused on what strategies can best facilitate the adoption and integration of evidence into a given practice. So the goal of dissemination research is really to understand how, when, by whom, and under what circumstances evidence spreads, focusing on all the stages of evidence from its creation to its reception. And these are important steps that we often jump over. In implementation research, we try to draw a contrast from what we are used to seeing in typical clinical trials, which tend to focus on the what, as seen on the left, all the way to the right, the health outcomes that we are trying to improve. So most trials are predicated on the idea that if we focus on the left and we focus on the right, we'll get the answers that we need. What do we need to do for a given patient, and what are the outcomes we're trying to improve for them? But what we jump over is this important middle, and that's the question of how. The implementation strategies that will support our ability, the ability of those interventions to be delivered in a whole variety of settings in which people are seeking help. And importantly, what are the implementation outcomes? So if we get implementation right with those strategies, if we can enhance implementation, we should see that those strategies will allow our interventions to be deemed feasible to be delivered, that they are acceptable to populations using them, that they can penetrate as far into the systems and as far into the communities so that they reach as many people as possible, and that they are sustained over time and have high rates of uptake, and that we're also understanding the costs. So when we start to focus more on implementation science, what we are ideally seeing beyond the usual is that we can have an influence on implementation outcomes, which then has a knock-on benefit on the service system and at the population level. And just to clarify what we mean by implementation strategies, those are the strategies that we use to ensure or enhance the adoption, implementation, and sustainability of an intervention. So some examples of strategies include things like strategies to educate or train practitioners to effectively adopt and deliver, as well as strategies to ensure practitioners can incorporate these interventions into their workflow or integrate them into their community settings. And evaluative and iterative strategies to ensure implementation fidelity, and where necessary, strategies for adaptation for a given context. So how would you select these strategies? It depends on what barriers you're trying to overcome, what resources you are able to leverage, and who are your stakeholders. And so we really need to move away from only thinking about that interaction between the provider and consumer. We need to consider all the levels in which that relationship exists and how those different levels can affect implementation. So when we've historically ignored these levels, we leave out populations who don't have as good access to care. So how can we best get organizational change? How do we best get communities and states to support the implementation of these interventions? It's particularly important to engage key stakeholders and build the evidence base to support implementation at each of these levels. So how do we apply this work? Implementation science hinges on theories, frameworks, and models to help us understand dissemination and implementation processes. We have over 60 in the field, and actually I think the most recent review of models estimated over 150 in the field. Point being, you don't have to start from scratch. So I'm going to review just a couple examples, which are two of the most prominently used examples to date in our funded portfolio, but that's not to say, and I won't, and Russ's is a third, which I've already mentioned and you all are very familiar with. But here you can see Everett Rogers' theory on diffusion of innovations, which is one of the oldest theories in the field. And what Rogers highlights is that the decision to adopt and the ability to implement effectively is influenced not just by the characteristics of the intervention itself, but also by organizational characteristics and the environmental context. So these are important things to consider and measure when trying to figure out how best to implement your intervention. Another popular framework in implementation science is the Consolidated Framework for Implementation Research Development.
Gila, excuse me, this is Russ.
Yes.
I at least can't see the last couple screens. I didn't see diffusion of innovation or the new one. Don't know.
You did?
Others? I saw all your slides until that one.
Yeah,
Oh no.
We stopped advancing.
So I am looking at my Rogers slide. You guys don't see that?
I don't anyway. I don't know. Jordan or others, do you? I'm afraid we might have most people muted, but it just stopped all of a sudden. Okay, everybody else is saying they're stuck too.
Do you want to try unsharing and reshare it too?
Shall I unshare and reshare?
I think so. I'm going to leave this to Jordan or Brian.
I'll stop sharing, and I do apologize. I have had a lot of connectivity issues, and it actually does seem to start in the afternoon. So let me try again. Do you see my screen?
Yes, we can, but it's still on the same slide.
It's on it should be on Rogers, yes?
No, it's the one before that. It's on the Proctor et al. Kind of logic model.
What do you see now?
I see the same thing. I'm trying to watch chat now. Boy, we're getting different things. You know, I don't know, unless Jordan has a suggestion, maybe we'll go. 2 people or 3 people are saying they just see blank screens, and others said they see one titled Implementation Research, but others have black screens.
So I see.
So I don't know. Oh, go ahead.
Oh no, so I'm seeing the Rogers slide, the diffusion of innovation slide. But
It just came up on mine. It just came up literally as you were talking.
Too, yep.
Okay, others are seeing it too. So let's go ahead. Sorry to interrupt, but you know, technology.
Yeah, no, we're learning to adapt. Well, now I've advanced it because I'm done talking about Rogers, although I think hopefully folks, basically this slide, did folks hear me? I mean, this is a very simple slide just highlighting that adoption and implementation are influenced not just by the characteristics of the intervention, but as folks know, organizational characteristics as well as environmental context. And I wanted to, you can basically see here with Laura Dam Schroeder and her colleagues, Consolidated Framework for Implementation Research. It's a lot of the same ideas. So they highlight the importance of thinking about the inner and outer settings. But what they add here, when thinking about the intervention and the characteristics of the intervention, you can think about an intervention having both core components and an adaptable periphery. So where you see on the left, you have your intervention that doesn't quite fit within the setting, but it can be adapted to fit within a given context. So, so their idea is that you go through an iterative process, and they outline various implementation processes from planning to evaluation, where you can go through these processes where involving these various stakeholders, where you reach the right side of the slide, and engaging stakeholders at various levels to determine how best to adapt your intervention and identify strategies to enhance its likelihood of reaching the right side of the slide, where you would have an intervention that has the same core components, but its adaptable periphery now fits well within the context and is adopted, effectively implemented, and hopefully sustained, and reaches the populations who can benefit from it. So, so moving on to funding opportunities, and I will go through the main one of these and then pause for questions. So essentially wanted to highlight that the NCI, along with 20 other institutes, centers, and offices across the entire NIH, have issued these funding opportunity announcements to support implementation science. And to date, well over 200 grants have been funded across the NIH over the past decade. In addition to these three mechanisms, there is a standing study section, the Dissemination and Implementation Research and Health Review Committee, that does have the appropriate expertise to review these grant applications. There are also a variety of program staff available to answer your questions about these opportunities from all of the represented institutes and centers. And so these mechanisms are an R01, an R21, and an R03. And just to show you the alphabet soup that is NIH, these are the different institute, centers, and offices that are signed on. And you'll notice for the different mechanisms, it's not always the same. So if you are going to apply for these, make sure that whichever institute, center, or office you're targeting is in fact participating in that announcement. But just wanted to highlight that the purpose, as described in these funding announcements, is to support innovative approaches to identifying, understanding, and developing strategies to overcome barriers to the adoption, adaptation, integration, scale-up, and sustainability of evidence-based interventions, tools, policies, and guidelines. And also wanted to mention that in addition to thinking through how to implement things, we also highlight the value of understanding how to stop or reduce, aka de-implement, the use of interventions that are ineffective, unproven, low value, or harmful. And so this is an area that we hope to see more of, given how much of this is happening and what a real problem we've identified this to be. In addition, these funding mechanisms are used, and we encourage researchers to use them to advance research methods and measures in the field. So just to give you an idea of some priority research areas and questions that we've laid out in these announcements, and I do encourage you to take a look at the announcements themselves, but I've just pulled out a few areas that we highlight that looking at how we can best adapt our interventions and capture those adaptations for specific contexts. Also thinking through studies of strategies, and not just what strategies work, but how and why they work. So really understanding the mechanisms, moderators, and mediators of those strategies. Also a focus on scale-up and sustainment of effective interventions and the most effective strategies for doing that, as well as strategies for de-implementing practices, as I had mentioned earlier, that are not evidence-based or harmful or wasteful. So I just wanted to give you an idea of some examples of grants that NCI has funded through these mechanisms. And you can see here they span a variety of topics, not just across the cancer control continuum, but in a variety of settings: after-school programs, community health centers, low-wage work sites, and other work contexts. And a few other examples, and I wanted to pull out these a little bit because I wanted to walk through some examples of specific aims in case that's helpful, particularly for folks who have not actually written grant applications to NIH at this point. in terms of thinking about the kinds of specific aims you might find in these. And all of these grants that I'm flashing up here, you can see that little tab, View Funded Grant. These investigators have given us permission to post the grant online, so you're welcome to see those. But just to walk through a few examples of specific aims, for Alana Ram's Lynch syndrome screening R01 that was awarded, she set out to describe variation in Lynch syndrome screening implementation across multiple healthcare systems. And just going back, this is a grant implementing universal Lynch syndrome screening across multiple healthcare systems, identifying strategies to facilitate and maintain programs in different organizational contexts. So she also sought to explain practice variation and determine factors associated with optimal implementation, and determine the relative effectiveness, efficiency, and costs of different screening protocols by healthcare systems, as well as develop and test an organizational toolkit for LS screening. For Ted Scolaris's grant on prostate cancer treatment, and this was another R01, he sought to assess and is in the midst of assessing preferences and barriers for de-implementation of chemical castration in prostate cancer. And he's using a discrete choice experiment to identify de-implementation strategies and tailor them. And then finally, pilot two tailored de-implementation strategies. And then finally, in Ben Teeter's grant, and this was an R21 on HPV, how-to strategies for HPV vaccination in community pharmacies, he sought first to identify barriers and facilitators to community pharmacies' provisions of HPV vaccine through a mixed methods design with pharmacy staff members and local physicians, and then to select a pharmacist-physician collaborative model and identify strategies engaging key stakeholders, and then finally to pilot in just 2 sites in 2 pharmacies those strategies. So that's building work towards a subsequent R01 where they can do a full-scale trial if on promising strategies. So that's just to give you some examples. Officers, and for many, is that reaching out to us, you can identify your relevant program officer on the program announcements. And we encourage you to then send them a one-page, your specific aims page, highlighting any specific questions you may have, but essentially asking, it's reasonable to ask for a brief call. Now, we try to be as responsive as we can, and perhaps now that we're not in the office and perhaps with fewer obligations, we'll be more responsive these days than normally we are when we're traveling about. But don't be shy to email reminders if you don't hear from us. And then finally, just wanted to end with some resources available on this funding mechanism.
One or two, but the one that I have right now ask about going back to the Proctor model slide, thinking about over time kind of logic model. The comment was
I'm afraid if I go there, we'll get stuck. But
oh yeah,
this one.
Well, I think people can visualize it. Maybe let's hope not. There's a lot of focus on in our field implementation outcomes. Traditional health services research focuses on health outcomes on the right, but not so much on service outcomes, at least what I think we see. And these things are, I believe, those come up from the IOM recommendations from a while back in terms of those key service outcome criteria. And I'm just wondering if you would concur with that. And then if so, do you think this is an opportunity or an area that implementation scientists ought to be paying paying more attention to, or just any other reflections?
So absolutely, and I'm particularly honing in on this concept of equity. Now, I mean, I think first and foremost, we're focused on these proximate implementation outcomes, but I think that, you know, particularly with regard to equity and patient-centeredness or consumer-centeredness, I think these are things that we can do a better job as a community integrating into our thinking and ensuring that our strategies are, perhaps they may make an intervention more feasible, but that doesn't necessarily mean it will improve equity. So taking these things into consideration, I think, is something that many people in the field are thinking about. How do we do a better job? Does that get at your question?
I'm pretty sure it does. They can't speak, so I'm going to say, knowing Amy that asked the question, I think it does. The other thing I might add, and then we'll let you go ahead, hopefully you can advance, but the other top one there, efficiency is really related to cost as well. And that's something I know they're going to see that future as you go forward, Gila, but as you know, that's kind of one of the areas that many of us are focusing on campus here. And unfortunately, the dang thing stuck again.
No, I just haven't. Can you?
Oh, okay, good. We're going now. So why don't we to the moonshot and the other thing?
Okay, and yeah, and I do think that people are thinking through how do we incorporate more of an equity lens, and how do we develop more standardized ways of measuring costs of our strategies, so that we are explicitly thinking about these things up front and not just seeing it as a knock-on benefit and assuming that our efforts will actually result in improving these things. So yeah, I'll mention that a little bit before, but in terms of the Moonshot initiatives, so while NCI historically had primarily funded implementation science through those program announcements, since the 2016 launch of the Cancer Moonshot, there were three areas where implementation science was incorporated to address these three priority areas to advance cancer control, and that was in the implementation of evidence-based cancer prevention and screening, in symptom management for cancer patients, and in addressing hereditary cancers. So these are some of the funding announcements that sat within those. Some of these incorporated implementation science to greater or lesser degree, but particularly in those red and blue, it was a big part of it, as well as impact and symptom management. But really the big one that we're also excited about, we're excited about all of these, but the implementation science centers, where we really see, while they have primarily focused on prevention and screening by developing this infrastructure and this capacity, could really address all of these issues. And that's why you see that kind of surrounded by the multiple colors. But just wanting to walk through a few of these. So the Cancer Moonshot has enabled NCI to concentrate on important opportunities in implementation science in these areas. So accelerating the delivery of colorectal cancer screening, follow-up, and referrals, particularly in underserved areas. Enhancing delivery of tobacco cessation treatments, developing approaches to identify and care for individuals with inherited cancer syndromes, as well as developing these centers. So just walking through a few of these examples, we have the Accelerating Colorectal Cancer Screening and Follow-Up Through Implementation Science, our ACCESS initiative, which is led by Sarah Cobrin in our Healthcare Delivery Research Program, in collaboration with Wynn Norton on our implementation science team, and others across our division. And so these were essentially collaborative agreements and a funded coordinating center to generate implementation strategies that would substantially improve CRC screening and follow-up with an emphasis on underserved areas. So in the next slide, you can see the areas where these grants were funded, and it really does span across the country. the different colored stars are sort of the different mechanisms. So the yellow ones are the main access research projects, but you can see these green stars at the bottom, which were added to this consortium, but funded separately through our native populations, tribal populations, AI, American Indian population. So we have a span of projects there. Additionally, I wanted to mention that we have this Cancer Center Cessation Initiative, and that's essentially administrative supplements that have been issued to comprehensive cancer centers to develop, and I think all 42 perhaps, I think 42 of these received these supplements, and this is to develop tobacco cessation treatment capacity and infrastructure for cancer patients that should lead to the implementation and dissemination of a sustainable tobacco cessation treatment program. And so you can see there, I think it's number 10, is you guys have received one of these. So, and our coordinating center is at the University of Wisconsin, Michael Fiore. But this is an opportunity to capture data on implementation strategies to integrate cessation services into cancer centers. In terms of approaches to identify and care for individuals with inherited cancer syndrome, we had this announcement to promote research that identifies and tests methods to increase case ascertainment and optimize the delivery of evidence-based follow-up healthcare for individuals at high risk of cancer due to an inherited genetic susceptibility. And you can see we've funded 4 of these. And on a related note, communication and decision-making for individuals with inherited cancer syndromes, where the goal of this was to develop, test, and evaluate interventions and implementation approaches, or adapt existing approaches to improve patient-provider family risk communication and decision-making for individuals and families with inherited susceptibility to cancer. So the first issuance, there was 1 funded, and I know that review has happened. I'm not sure how many came out of the second round, but that was recently announced. And finally, which I know many of you are familiar with and some of you are doing and leading, thank you, Russ. We also funded 6 implementation science centers in cancer control to support the rapid development, testing, and refinement of innovative approaches to implement a range of evidence-based cancer control interventions. So all of these centers are featuring an implementation laboratory, as well as advancing methods in studying implementation and developing and validating reliable measures. And I believe that all of the centers are coordinating efforts to do that simultaneously, or to focus on certain measures to advance those. And so really an opportunity to coordinate those efforts across the centers. And so my colleague Cynthia Vincent and and you can see University of Colorado is on the map. And so this is just the list of those 6 and the topics they're addressing from, you'll see equity pop up a lot, also the use of technology and adaptation, and for the first time. So I just wanted to mention this encouraging message that NCI really does see implementation science at its highest levels as a key priority area to advance cancer research and population health. So we do hope to see increased investment in this area in the coming years. Now, I did want to mention also, and this is some of the stuff I've been thinking about as an epidemiologist. So our team, in addition to supporting the advancement of implementation science, we also think about how implementation science fits within the broader research continuum. So here you can see the traditional translational pathway for intervention development, testing, and implementation. But if you're at an earlier phase in this continuum than that purple circle, you could think about how to design your study to make it more likely that the ultimate intervention will be implemented. So one way to think about that is through pragmatic trials. And so thinking through how do you design a trial where rather than the focus, and this idea is trials can run the continuum from being more focused on efficacy and how things work in an ideal setting to really understand the mechanisms, to how things work in the real world and what we can expect. And so with the trial's purpose of informing practice. And pragmatic trials are trials that intend to inform practice. And so this is the PRACE-2 wheel, and given that these folks, I'm guessing probably everyone on the call may be familiar with this. Russ was the one who taught me about this and got me very excited about this tool. But what they've done here is they've outlined 9 dimensions where you can think about in designing your trial to make it more pragmatic so that the work that you're doing is really more likely to inform practice. And this just illustrates the point that when thinking about testing the effectiveness of an intervention, you can also be thinking about its implementation to inform practice. So for example, not only can your eligibility criteria be broad, including patients likely to receive the intervention and in settings where the intervention is likely to be implemented, but further you can think about what additional resources would be required for an organization to deliver the intervention and whether those resources would be feasible in practice, as well as how intensely you are monitoring delivery and adherence. So each of these dimensions can be viewed on a continuum and can help us in designing trials so that they meet their intended purpose and understand to what degree they are in fact pragmatic. So another way you could be thinking about implementation science earlier on is by incorporating research aims around implementation within our trials directly. So not just through pragmatic trials, but actually integrating implementation aims. So we can be thinking about who will deliver and receive the intervention, and we can build in tests of the implementation strategies to see whether they can enable the interventions to be used in practice. So even while we're collecting that evidence on effectiveness, we can be thinking about implementation early. So thinking about, will those strategies enhance those implementation outcomes of adoption, implementation, and sustainability? And one way we can do this is through hybrid design. So Jeff Curran and other colleagues at the VA have laid out a roadmap for how we can incorporate implementation aims into our effectiveness studies. And as you can see here, hybrid designs include both research aims about the intervention's effectiveness as well as its implementation. And they've laid out different types depending on which aim you're more focused on. And so essentially that's all I wanted to mention there. You can see the reference below, but they've actually recently released new guidance on how to think through these 3 different types. So finally, just wanted to mention a few additional resources at the NCI, namely our team. So I'm part of a large team, the implementation science team at the Division of Cancer Control and Population Sciences. And on our website, you can find out more about funding opportunities, research, and training. So I encourage you to visit our website. And there you'll find resources on training programs. We have our Training Institute for Dissemination and Implementation Research, which is now open access. So all 5 modules, all 6 modules can be obtained free. We also have webinars, as well as Russ mentioned earlier, hosting the annual conference. Additionally, there are textbooks in the field, including most recently one focused on implementation science and cancer research that was released a 1.5 years ago. So just wanted to conclude with a few additional priority research areas that have been highlighted by this recently launched Implementation Science Consortium. And while it's called the Implementation Science Consortium in Cancer, really these, the folks who attended and the focus of the topics have broad implications for implementation science across health areas. So last July, NCI convened implementation science experts from around the country and in the world, 107 people in person plus 136 attendees online. Now this consortium was convened before we announced the awardees for the centers. So while it did include many of the investigators from the implementation science centers, it included many, many others as well, with the idea that this consortium is really a big tent, inviting all comers who can contribute to and have great value towards advancing the field. So the goals were really to build capacity, collaboration, and a new model for collaboration, and to articulate and create a vision for implementation science across cancer and beyond. So subsequent meetings will be hosted by, and this is part of the contingency for those checks to the centers, is that they continue with this model of hosting these consortium meetings and maintaining this big tent. But for this first meeting, I just wanted to highlight the 7 areas that the steering committee identified as areas that were really ripe for advancing the field, priority research areas. So thinking through implementation laboratories, and Russ was actually one of the leads on that. So I won't say more on that. Russ can, if you have questions, he can answer them. But also a focus on our methods and designs and how to advance our rapid cycle designs, a focus on economics and cost and how do we do a better job of measuring these things, such a critical outcome, but where there's been a real gap. Also a focus on the use of technology, and as I mentioned earlier, integrating health equity and having more of an explicit health equity lens in our work, as well as a focus on implementation of policy. This is an area that I think, based on our portfolio analysis, there's really a gap here in understanding the most effective strategies for communicating with policymakers, implementing policy, and finally, a focus on precision medicine. So over the course of 3 days, these 107 in-person folks met and hashed out across these 7 areas, what are some what are some major gaps and potential solutions? And over those 3 days, they laid out 20 different projects that were fleshed out. And what this graph shows is, this column on the right shows just a summary of what those 20 projects were. And you can see these dots basically represent, at the end of the 3 days, folks voted on what they saw were the projects most likely to have a real impact on the field and priority, that were prioritized for being critical. And so I guess it's hard to read from this graph, and I'm sure there's probably new iterations of this graph in process, but essentially there was real interest in prioritizing the health equity, measuring costs, and rapid cycle design development. And I would say in the context of what's happening now across the world, methods for rapid cycle design would be critical, as well as understanding costs and equity issues, as well as the use of technology. So really, these are all areas that now we have a variety of working groups trying to advance. And on our website, we have a summary that we periodically update to let folks know how these things are moving and provide opportunities for getting involved. So I think I'll end there, Russ, and happy to take questions about this or any of the other material that I talked about.
Well, thanks so much, Gila. An awful lot, very efficiently done. So I really want to thank you. Again, I want to encourage people to type in questions on chat. We don't have very many right now, but unfortunately, we're also having a process issue. I have at least one note here that some people are having trouble with Zoom and the chat feature, that they can't see the chat feature or else it causes them to lose Zoom or close down. So I'm going to start with one question, and then at the risk of inviting a lot of chaos, I'm going to ask Jordan if he could, or I'm not sure, Jordan or Brian, unmute people or ask people to unmute themselves after that, and we'll see how that goes. Since some of you are having trouble, but we'll just try to take turns that way. But again, if you can use chat, that would help a lot here. But to start off, while people are either chatting or Jordan's getting ready to unmute people, a general question about funding, Gila. You sit in on a lot of the reviews there, and I'm just wondering if you have thoughts about either frequent, if you will, mistakes people make or things to get people into trouble with review, frequent reasons they aren't funded, and conversely, like key things that you've seen do really well. What do reviewers seem to really like?
Yeah, that's that's a great question. And actually, I'm remembering a previous iteration of these slides had included something on that. But essentially, never skimping on your approach or your methods. I think a lot of a very common mistake is that, and also always justifying your decisions. So that's going to be true in general. In D&I, what I see a lot of is not going enough into, let's say, the qualitative methods, not having the appropriate expertise in place. But really, it's critical, I think, not to skimp on the approach and justifying all of your choices. Those, I think, are some of the biggest pitfalls that we see. One thing, when we did have our last training institute last July, we were lucky to have Steve Bartels, who's the chair of DIRH at the moment, participate in that. And he also highlighted an interesting point that, the field has really evolved, whereas maybe 3 or 4 years ago, folks would say using a hybrid design was a source of innovation. That's really no longer a source of innovation. That's just kind of very common standard. So also thinking through like what you, what you would call innovative about your study. But I think the approach is the major place where folks end up sinking.
Super. I've got a couple more here, but again, then why don't, if we can, Jordan, you can unmute people. Please only unmute yourself when you're going to speak, so we don't get a lot of background noise. But one of the questions we had, kind of follow up to that, is how critical is it to have a, quote, card-carrying D&I scientist on a grant if you want to get funded?
So I do think for DIRH, that is something that's pretty important, that you have some implementation science expertise on your team. And, how you justify that or demonstrate that, you can be creative, I imagine, but that is something that the review committee expects to see, is that you can justify that you have the appropriate expertise.
Super, thank you. Hopefully we can keep going here. I'll try to be brief in the questions. Gila's doing a great job of being brief on her answers. Why don't we go, I know a number of you probably need to go at the top of the hour. Again, the whole group can go at least a little longer after that. So let's give priority to anybody that has to leave in a couple minutes. You can go ahead and ask a question now, particularly if you have to leave soon, and if not, we'll get to you in a little while. Well, while we're waiting for that, let me do another one. Again, those of you that can do chat, please do. But the question was in the nice little graph that you had there, Gila, of all the different ideas. Yeah, and they were ranked on priority and impact. Said there one of the highest ratings was for a, quote, checklist on health equity requirements. And could you just explain that a little bit more, what was meant by that?
I can't.
Number 5, looks like number 5, I think.
Yeah, no, I see that. And, you know, so I was solely involved with the economics group. I will say that I know the health equity group has been very busy writing and publishing papers. And the one that I was involved with in a bit with the equity group was on, So I know that they're thinking about how can we do a better job? What are the gaps in implementation science and involved in terms of having explicit incorporation of health equity constructs, so that number 3 piece. And yeah, I'm not exactly sure, Russ, what that is. And I think some of these projects have evolved. So I probably shouldn't have left this slide up long enough for you to be able to read all the details here, because I do think some of these things have evolved since then. But I do know that they are thinking through general concepts on how do we build more of an explicit health equity lens. Now I'm wondering, do you know more about this one than I do, and are you just setting me up? Just a fair question.
That's right, yeah.
If you do, please answer.
It's not my question, just so you know. No, I don't. But I do have a question kind of related to this, and then one other thing. I'll try to be concise here too. And both on this, one of the issues that came up is policy and the importance of policy. And you also mentioned from some of the portfolio analysis you've done, that's one of the things that you don't see much of compared to kind of standard interventions. Could you just elaborate a little bit more, or maybe give us examples of what might be some of the key D&I issues in policy that you can see that deserve greater attention?
Well, I think the best source of information, well, a good source of information is actually the NCI annual plan, in which we not only highlight implementation science as a key priority area, but we feature Ross Brownson as one of our funded investigators who really has been a leader in this area. And he's focused on, strategies for communicating with policymakers, strategies for getting policymakers to implement effective evidence and interventions. And he kind of coined this term misimplementation, where we not only do things we shouldn't do, but where we don't do things we should do, and where we stop doing things we shouldn't stop. So all the various ways in which things can be misimplemented. And so that's highlighted in the annual plan. But I do think in general, as a team and as a field, we haven't done as much thinking around effective strategies for communicating with policymakers as stakeholders, engaging them as stakeholders. And so those are things that our team is actually actively thinking through now and trying to build more work around.
Great. I might just editorialize a bit. Then we have one more question on that. Building on it, to me, it seems like one of the opportunities around policy is many of us are focused on trying to work out what are key contextual factors. And we know context is critical, but thinking about the interface or interaction between policy as a key contextual factor and the evidence-based intervention and the implementation strategy that you take. And I guess one example I'm often thinking is the possibility to use policy when new things come out, particularly like several folks here work on areas that like their new CMS guidelines and reimbursement on. When there's a policy there that providing an opportunity, to really jumpstart, so it doesn't take 17 years, maybe might be one possible way to think about that.
Absolutely. Yes.
The next question I have is, could you speak to proposals that focus much more on prevention, and maybe particularly primary prevention, like physical activity, diet, nutrition, and are those seen as relevant to NCI and to other institutes, or is the focus really swinging all to biology and precision medicine?
No, I mean, the vast majority of the grants we've funded through these announcements have been on primary prevention and screening. But particularly, I think we started with tobacco cessation, actually. But we've also funded grants in diet and nutrition and physical activity, and how to improve implementation of a variety of programs to enhance physical activity and diet and nutrition. In terms of where we're headed with that, I mean, one thing because we've seen a disproportionate number of grants in that area, yet we have this silver tsunami of cancer survivors, we do want to see a bit more in the other side of the continuum. But across the board, and our Office of Disease Prevention is signed on, this is still very much a relevant area, and traditionally has been where the bulk of our focus is.
Great. Could you, a double-barreled question here.
And I should say, in terms of HPV vaccination, that's a key priority area. And I do see that one of your colleagues is focused there. So that's obviously relatively new.
Great point. Yeah, and that is something, as you're right, that we have a lot of emphasis on here on campus. Another one is at least a good number of people focus on survivorship. So you kind of mentioned survivorship there, and that might be an area, but I wonder if you just want to elaborate a little bit there, if you have any particular funding opportunities or key implementation science issues. And then if you would just say, and maybe this is combine the two, but a bit about RTIPs. I think a lot of people don't know about RTIPs, and kind of your thoughts about it and how people might use it.
Yeah, so RTIPs is our Research Tested Interventions Programs database, which is a database of programs, evidence-based programs that span primary prevention, programs to enhance cancer screening, as well as survivorship. So we host that database. We are in the midst of, we've done extensive user testing and extensive evaluation, and are in the midst of thinking through some overhaul, because I think it's primarily been used by researchers more than practitioners, whereas I think the hope was it would be both. But it's basically a database of research-tested interventions. So, Russ, was there something I've already forgotten that you wanted me to say in particular about RTIPs?
No, I think that was good. I just wanted to, as you know, one of my many biases is I just think it's a really great resource that people could use more, particularly to select an evidence-based intervention, which is always one of the big challenges. And then, to think about how, and maybe even doing CER ways to implement those programs or something like that, addressing many of the issues of generalizability, equity, that sort of thing. But if you could, the other issue was, and I don't have it up in front of me and I forget, like how many survivorship programs there might be, but just more generally. Again, we have a lot of people that have interest in survivorship here at the Cancer Center and otherwise. If there are any key D&I issues that you see coming up or any particular funding opportunities in that area.
So I know that we are increasingly focusing on survivorship issues. I would have to stop sharing my screen and go look up our tips to see how many programs are up there, which I am glad to do because I could quickly pull a number for you. But in terms of, you raise a good point that people don't have to start from scratch. If you have a particular problem that you want to address, you don't have to invent the intervention. There are a whole variety of interventions that exist. And just looking at survivorship, for example. So actually I could share my screen and show you the program. Would you like me to do that?
I think that would be really cool for people. Yeah.
Okay, let's see. So here is at the top of every NCI webpage or every NIH webpage, you're going to see this COVID-19 note, but here is the Research Tested Interventions program. And what I did here is searching for programs, so you can see the programs are organized by topics, by age group, by setting. And so if you go to topics and you click survivorship, and search, you can see there are 19 entries of survivorship programs, a variety of different cancer survivorship programs. If you want to know how many programs there are in total, 202 at this point. So point being, you don't have to start from scratch. Which also reminded me back to your question on review and what are some major pitfalls. I think one pitfall is also when folks are not familiar with the extant literature and maybe trying to create or test something where there's something else that already exists and we already know implementation about some things on implementation of it. So I think really familiarizing yourself with the variety of ways in which people have tried to address a particular problem that you're trying to solve. And if it's in cancer, you can always go here and look and see what are the variety of interventions that already exist.
Super, thank you. I'll just mention one other thing about our tips is in addition to just being kind of passing some criteria for being evidence-based, there are a lot of, if you will, application and implementation materials for that. Often there are manuals and guidelines and things for implementing it. Sometimes there are measures that were involved, protocols, that sort of thing. So the idea is it's not just this repository or list of studies or whatever that are there, but it's supposed to have resources. And that was, again, as Gila mentioned, part of the vision for people to go there, be community or clinical programs, be able to look at different programs, and then decide which one might work for them, either for application in their community, for implementation, or for implementation science. But since you pulled up the website, and that was really helpful, I'm amazed that the COVID-19 question hasn't come up so far. So could you just say a little bit about that, what you can say, and particularly implications for us researchers and things out there, both, some of the crises questions we might have, and also what opportunities there might be?
Sure. So review, funding and review is continuing. For those who may be affected, we recently issued this notice, flexibilities available to applicants and recipients of federal financial assistance affected by COVID-19. And so here you can see the details of that. Our office, our Office of Extramural Affairs, or Extramural whatever OER stands for, extramural research. They have a whole variety of resources of information for applicants and recipients related to COVID-19. And then you can also see, so our NCI director recently released a blog highlighting, essentially saying, you know, review and funding and review will continue and in cancer, because this is, you know, will continue to be an important health area. But also you can see Mike Lauer, who's our NIH deputy director, posted a video providing guidance to NIH and NIH-funded investigators, or those who are seeking funding on updates related to coronavirus. So we will continue to have those pages updated. We continue to have meetings and town halls, but we are trying to be as accommodating as possible. And I think that purpose of that notice for flexibilities is really our effort to do that.
Super, that is really helpful. I'll invite once again, since I'm not seeing any chats, if anybody audio that isn't able to see the screen or is just on phone, feel free to unmute yourself and ask a question. But while we're doing that, Gila, I hadn't thought of this, but you're doing a great job of sharing your screen.
I just saw.
If you just want to take a little run through your own site, the Implementation Science website, for people that haven't seen that, and some of the resources there I think might be fun for people to see.
So so here you can see we have our webpage. Under funding opportunities, you can see the sample grants that I had pulled up, as well as our funding webinars describing these opportunities, and a fact sheet about the program announcements. We also have, under our initiatives, the Implementation Science Consortium in Cancer, as well as the centers. And here, this is where you can see from that July meeting where we laid out those 7 areas and 20 projects. You can see the breakout group topic descriptions, who was involved, what happened on the 3 days, who was on the steering committee. And I believe that any updates to those projects will eventually be posted here. You can also see a variety of training opportunities, webinars, and that's also where you'll find our TIDERC open access. And then here we have a variety of tools. So research tools, we have tools for researchers, tools for practitioners, and then research practice partnerships. So here you can see links to resources for different areas. So there's in models, theories, and frameworks, we cite some key articles, and as well as, I think this is probably the website that Borshika developed, on selecting a model, framework, or theory. We also have an area of resources focused on measures and outcomes and on strategies. And so you can see for each of these, we have either archived webinars highlighting the issue, a variety of articles related to the issue, also methods and study designs. So, and then some other external resource hubs that we cite, as well as textbooks. So that's for researchers. There's also something similar for practitioners, where we have this Implementation Science at a Glance, as well as Cancer Control Planet, our tips, the progress report. And then you can learn about our team and the variety of folks on our team. So our fearless leader, David Chambers, and then all the other folks on our team. You can see web pages. And Karen Emmons from Harvard is currently doing an IPA with us. So anything, and where she's in part largely focused on policy and implementation science. And in addition to our team, we also have some dual appointees from our behavioral research program and our healthcare delivery research program. So yeah, there you have it. I think, and then we have our newsletter and our blog, as well as our Twitter channel or feed or whatever you call it.
Well, thank you. That's super. I might particularly point people to the example funded grants, I think, which are really useful. I think nice to have.
And this is our most visited website.
Is
So
that
this
interesting?
is our highest traffic, yeah. Here,
And
so you can see we have a variety.
yeah, and then also working, thanks for sharing that, also for working with partners. Again, Margaret can send me a little check, but the implementation science at a glance, I just think is really nice, kind of almost common sense language for sharing with stakeholders and community partners myself, and things have found that useful. And something else, and it's a PDF on there that people can download.
Yeah. No, it's really accessible and a nice summary, and it highlights some case examples, which is nice as well.
Thank you, as does the book. Why don't I give you a chance to push the book? Can you find that, the oncology particular D&I?
Oh, the textbook?
Yeah, the textbook that David and Cindy and others did.
Yeah, we don't link to it. You know, that's a Oxford Oxford thing, but we do have the reference here, and in my slides, I flashed up a picture. But that's Advancing the Science of Implementation Across the Cancer Continuum. So that's the textbook you're referring to that was released in October 2018. And so David, Cindy, and Wynn were the editors. And in my slides, if I pull up my slides, do you see my slides, or do I have to share my slides?
No, we're good. We're good.
Okay, that's this book here. Yeah.
Well, that's super. Given the time and that I don't see any other questions, this has been just phenomenal and really helpful. Let me just see if you have any final words for us, Gila, as we go forth into the great implementation science world.
Oh, and Russ, I think there is just one more that was asked, which I'm not sure there is the option there, but if there's any example grants for early stage investigators like K awards or other pilots.
So, so through the funding mechanisms that I said, those are not, those are just the R01, R21, and R03, but we certainly have, you know, there's the K-12 program that NHLBI and Russ is involved with. So there have been K awards. We don't have those listed on our website. But again, I think if you reach out to program officers looking for specifics, you know, we are always happy to help provide you with relevant information, but we do not have examples of K applications on our website.
Well, thanks, Amy, for doing that, and tell David to get on that. We actually have inquired in the past for our K-12 scholars, have asked about that, and we don't see any of those on the UNC listing either, and we've talked to NHLBI, but that would be, I think, a nice resource for a number of training programs and younger investigators if that was possible. And, you know, we know all the details about needing permission and things, but that might be advice. I will just say one more thing, and then we can wrap up. But I, again, will remind people, Gila really is the lead on coordinating, you know, a whole cadre cast of characters, including some of you all may be asked to be on planning committee. But either anything you'd like to ask the group, Gila, about thoughts for the upcoming meeting, or maybe does anybody else have a question or comment about the meeting? And then I'll give you a chance just to plug assuming that the situation changes and we're going to meet the end of the year, you can maybe just plug that a little bit and see if there's any back and forth that either you or others would like to do around the annual meeting.
Yeah, no, I mean, I'd love to hear people's thoughts, especially in the context of everything that's happening now, of ideas for, you know, where we may want to go with this meeting, whether we have it in person or a series of virtual sessions. The planning committee will convene for the first time in April, but David and Lisa and I are already thinking about, you know, the implications of what's happening now and how we want to move forward. So whether we get to move forward in person or not, I think what's happening today presents a lot of interesting opportunities for the implementation science community to think about. And yeah, I'd love to hear what folks think about that. And either now or feel free to email me.
Well, I'm not seeing any right now. Again, why don't we wrap up for now? Again, really appreciate, especially given the context and everything. And I know you're dealing with kids at home and everything, as are a lot of folks here. So we really greatly appreciate it. And again, I think you did share people's email, your email with people there if they have follow-ups, and Gila has given us permission to make her slides available too. So we will post those on the website if some of you want to follow up. But sure, on behalf of all of us, it's been fantastic, much appreciated, and we still do hope, if things settle down and if possible, to see if we could get you out here in person maybe the end of the year or something for a more extended visit with several of us in different areas here.
I'd love that. And I did just see that somebody asked the question, my email is where, and so I did just put in the chat function to everyone my email, which is very simple. It's just gila.neta@nih.gov.
All right, Jordan, I don't know if you have any final things or if we're done here for today.
No final things. Thank you, Gila. Thank you, Russ.
Thank you. Thanks so much. Take
Bye,
care, everyone. Hang in there. And we really appreciate you working through all of this.
Thank you so much.
Thanks, everybody.
Take care.